and I am here for HIT 340 Comparative Records. This is now week 3, and this is chapter 3, and we are going to be focusing on freestanding ambulatory care. So let's dive in. What are our learning objectives? Well, we are going to look at freestanding ambulatory centers and talk about how they're a little bit different than hospital-based. We will be doing course objective 8.1 from your syllabus and unit objectives 9.11 and 9 through 9.115. So if you're looking at your syllabus, that's what we're going to be focusing on this week. We'll also be talking about the major agencies or organizations that set standards for these freestanding ambulatory care centers that are not a part of a hospital-based program. Look at their record completion systems, quality, coding, indexing, computer systems, payment systems, the organizations and agencies that regulate those. So let's start here. The largest segment of freestanding ambulatory care that is not owned or operated by a hospital or hospital-based, and this is dwindling rapidly, these are becoming very few and far between, are physician private practices. These are where the physician owns his or her own practice. It is not owned or employed by a hospital or healthcare system. It has been the largest portion of freestanding ambulatory care, and every year it shrinks dramatically. These can be solo practices or group practices. Public health departments that offer preventative services are also considered freestanding ambulatory care because they are, again, not owned or operated by a hospital-based care setting. Community health centers that meet the medical needs of an underserved area or population, those are also considered ambulatory, freestanding, non-hospital based. Rural health clinics, urgent care centers, and ambulatory surgery centers. Again, as long as they are not owned or operated by a hospital or healthcare system, they're on their own. They may be owned by a county. They may be owned by a Indian reservation. They may be owned by a physician, an individual practitioner, those types of situations, that's what we're talking about. There are also industrial and occupational health centers that are set up in large factories. University health centers, yes, this is another one. You may have a university that does not have a medical center associated with it, but they do have their own mini health center, and that is freestanding and it's not hospital-based. There are also independent birth centers that are not affiliated with hospitals, and then family planning centers also fall into here. And that would be Planned Parenthood. Types of patients: not critically ill, may be seeking wellness care, often have minor acute problems or chronic conditions, and sometimes they focus on a specific type or group of patient in a specific setting. Might be a pediatric clinic. Or maybe it could be a freestanding ambulatory surgery center where they perform hernia repair procedures and things like that that can be done on an outpatient basis outside of the hospital. The types of caregivers that work in these settings include physicians, nurse practitioners, certified nurse midwives, physician assistants, dentists, nutritionists, counselors or therapists, psychologists, social workers, chiropractors, and podiatrists. These are just the types that would. So for instance, if you have a chiropractor who owns his or her own practice, that would be an example of this freestanding ambulatory care. If you have a dentist's office, and let's say there are a group of 5 dentists in the practice, That would be a group ambulatory freestanding care center. You may have a large or a small behavioral health practice. And that, again, if it's owned by that group of providers, that's where it's at. Regulatory issues usually revolve around licensure. And it's interesting because licensure is mandatory for hospitals that are providing care. But it is not mandatory for a lot of these freestanding ambulatory care centers. So all the rules about quality, safety, cleanliness, how the environment is, the building, egress, all of that, fire safety, that varies. And from state to state, but also from freestanding ambulatory care setting to freestanding ambulatory care setting. For instance, physician offices do not have to be licensed usually. Now, the providers themselves do, but the office setting does not. There are ambulatory surgery centers, freestanding ambulatory surgery centers that have to be licensed, but there are family planning centers who don't. Both may provide procedures, medical or chemical, but the licensure differs. So I'm just pointing out that, and how the licensure differs is different. The providers all have to be licensed, but the setting itself may not have to be, and that varies from state to state and from type to type. So again, a chiropractor's office may not need to be licensed, and a behavioral health clinic may not have to be licensed. But in other states, maybe they do. It's just going to vary, and you're going to have to do research to know what your state requires. Medicare certification. Those COPs, or conditions of participation, they do exist for some settings, but not all. So there are plenty of settings that do not have to meet conditions of participation, but then again, there are others, like rural health clinics, and federally qualified health centers that do have to meet conditions of participation in order to get reimbursement. Theoretically, all are required to keep medical records. However, if you don't have conditions of coverage or conditions of participation or licensure that mandates that, it can be a bit of a toss-up. But typically, ambulatory surgery centers, rural health clinics, and FQHCs, those federally qualified health centers, those are ones that absolutely have to have medical records. And they have rules governing those through those COPs, or conditions of coverage. Accreditation is an entirely voluntary practice and process. There are these different accrediting bodies for outpatient ambulatory freestanding care, but none of them are required. Compliance. There are areas of compliance that do apply to these. All covered entities, of which these are, whether you're talking physician office or an ambulatory surgery center or a chiropractor's office or any of those, they all are covered entities, and they are subject to corporate compliance rules and the Office of Inspector General's guidelines. So from that standpoint, yes, they do have to comply. So they do need to be monitoring their coding and billing, their reasonable and necessary services, their documentation, making sure they don't do any improper inducements, kickbacks, or self-referrals. And then, of course, if they have Medicaid payment or Medicaid reimbursement, they are subject to the Medicaid Integrity Program, or MIP. Documentation in these settings. Typically, they will keep registration and demographic information. They may do history and physical, reason for visit, depending on what's going on, but typically they have to have that for reimbursement, so they keep it. Any kind of testing reports, they keep progress notes. They have encounter forms, which they call a super bill, where they mark off what maybe they put a diagnosis on there and they mark off the services that were provided, and that's used to bill for the encounter. They often keep copies of hospital records in their records so that they have that as reference or referral, so that they know what happened if the patient was recently hospitalized. And then they typically keep an ongoing running problem list of the patient. When did the problem start? When did it end? Is it ongoing? Those types of things. Most of these they have to have in order for reimbursement and corporate compliance, which again supersedes licensure and all of that, because if they're not required to be licensed or accredited, then they're not required to follow those rules. But they are if they're a covered entity, which all of them are, and then also for reimbursement. Record format, they are often source-oriented, arranged according to the source. All the lab reports together, all the nursing notes together, all the pathology reports together, all the history and physical reports together. The record is typically chronological order. The oldest visit on the bottom, the most recent visit on the top, or when you go to look in, the most recent visit is at the top of the list, the oldest visit is at the bottom of the list. However, it can also be problem-oriented. It's a lot more rare for this to be the case, but some do have problem lists, and essentially they link that. Let's say if you're the patient and you have 4 problems, they'll say problem 1 is asthma. And so all of your documentation, like your respiratory therapy tests, pulmonary function tests, would go under that problem. And maybe problem 2 is that you have trouble with psoriasis. So anything dermatologically related would then go under problem 2 in your chart. And say problem 3 is maybe you've been having problems with an old injury to your ankle, and you keep having some inflammation and some pain, and you've had to have physical therapy. And so all of your physical therapy notes are under problem number 3 related to your ankle, and so on. In this day and age, most have electronic health records, although still a few here and there plod along with paper records. Filing, they can do it based on a patient identifier. They can do it on patient name. It just really depends. And in terms of a numerical filing, you can do it straight numerical order. You can do what's called terminal digit or a family numbering system. And I would look in your textbook to go over the details behind these. And if you have a question, let me know, and I'll go through them in detail. I have spent hours of my life doing terminal digit filing. I have also done a little bit of straight numerical order, but most of the organizations, the healthcare organizations I worked for, when they had paper records back in the day, it was terminal digit. Last 2, middle 2, first 2. There are some people use color-coded file folders. Back in the day when it was all paper, there were cabinets, open shelves. There were even electronic files that moved. You could even have some that brought it up to you. You'd type in the number and it would bring the shelf up to you that you could get the number of the folder off of. When you talked about filing, you would get late reports. It used to be a real challenge with nursing units to make sure that they got all the paperwork down to medical records in a timely manner so that you could process the record once. I remember one summer I worked for a very large hospital, and they essentially, the medical records director went from unit to unit to unit to clean up all of their loose filing, all of their late reports and things like that. We ended up with 12 feet of loose filing, and one summer that was my job, was to take that 12 feet of loose filing and look at every single page, identify what it was, which patient it belonged to, which encounter it belonged to, and where in the record it belonged in that encounter, and put it in the right place. That was a long summer, but it got to be a challenge because it was fun to see that pile shrink and know that each page was going right where it needed to be, so that if that patient came back in, any provider caring for that patient would be able to get to it. Reimbursement. There are different types of reimbursement for these freestanding ambulatory care settings. There's fee-for-service, there's Medicare physician fee schedule, which is based on that value scale of RB/RVS. And I will tell you that in almost all of these settings now, in 2020, there are very few that use fee-for-service or RB/RVS. Almost all of them are under some type of capitation or other payment. MACRA has become the big thing, and we'll talk about that at some point. But MACRA has replaced RB/RVS for payments. So just keep that in mind. And we'll talk about capitation again in all of your classes, especially in HIT 292. And then you have Medicaid. Well, where can you go for resources about reimbursement? You can look at program manuals and program transmittals. You can contact your MAC and ask them about their Part B resources. You can look at LCDs and NCDs. And I know that we will be talking about those in some of your other classes this semester. So if you're not familiar with LCDs and NCDs, we'll make sure that you are. Those are very important because they will tell you what is covered and what you have to get that coverage. Coding and classification, they all use ICD-10-CM. Remember, we've moved from ICD-9 to I-10, and because they're covered entities, they're under that standard, the HIPAA rules and transactions code sets, as well as the corporate compliance rules. They're a covered entity. So they're both under compliance and under HIPAA. So they're having to use ICD-10-CM for all their diagnosis coding. They use CPT and HCPCS, level 1, level 2 codes for their procedure reporting and their services because they are all outpatient based. It's that ambulatory setting. There is an international classification of primary care, but that is very, very, very rarely used. Data and information flow. The visit is the basis of workflow. So that's where you're really looking at it. Their visit from when they come in and the whole process there, and then visit to visit to visit. So appointment methods, there's standard scheduling, there's block appointments, and modification of standard and block. And we won't get into a whole lot of detail there. If you ever end up being a registration person or handling appointments, you will be into this and know it cold. In the meantime, just know that there are standard block and modifications of those that can be used. Record linkage to other sites. Most of these have EHRs that allow access from various sites simultaneously, and also for electronic billing. If they're a paper-based system, they have to have things in place to be able to do this, to move records if they need to, as well as to submit them. And again, like I said, paper billing has become almost a thing of the past. Everything is electronic these days, and there are very few places that have not yet switched to electronic. And in those very few and far between paper-based systems, they have to be responsible for making sure that HIPAA that the privacy and security of that information is kept, and that it's available for when they have to justify for billing. And also for patient requests. Patients may ask for a copy of their records, and they have to be able to provide those to patients. And sometimes patients don't want them on paper, and how are they going to handle that? Computer systems, these types of settings typically have a patient registration, financial, They may have EHR, decision support, e-prescribing is very common, and then patient portals, how patients access their information, do scheduling, those types of things. They have what's called a Uniform Ambulatory Care Data Set, UACDS. That is about patient data, provider data, encounter data. And all of that has to be submitted. That's all through the regulations. They do some quality assessment and performance improvement. PQRI is another one of these acronyms that has completely gone away within the last couple of years. That's not done anymore. That's all part of MACRA. And since these are all providers that we're talking about, not a hospital-based setting, but a provider-based setting, they are all under MACRA, and they report their quality through there, as well as some other places. They have to do patient satisfaction surveys. They have to have some studies going on and prove that they're improving stuff. They have to report data, whether it's to the CDC or other organizations, to make sure that, that they're doing what they're supposed to be doing. Utilization management, they're supposed to be looking at appropriateness of services and treatment. They are supposed to be capturing incident occurrence reports and following up on those, resolving those, documenting all of that. They need to be examining their high cost or high volume services and looking at prospective reviews, pre-certifications, as well as retrospective reviews, and seeing how all that comes out. So what is the role of the health information manager in one of these settings? So let's say you end up finishing up and you are working for a large chiropractic group or a large behavioral health group. They're private, they're freestanding ambulatory. What are some of the things that you might be doing? Well, you definitely be managing information and supervising personnel, doing administrative tasks. You have to know the regulations and be able to communicate that and educate others on those. You need to have a good knowledge of electronic information systems and be able to help with those implementations and upgrades. And whenever you get a glitch, how do you resolve that? Need to be proficient at training and educating others and making sure that they are getting their training and education work done. And there are often non-traditional roles that are rolled into the health information manager. They do far more than just traditional HIM roles in these settings. Trends. There continues to be a shifting from inpatient to ambulatory settings. We just see that whether it's hospital-based or freestanding-based. Where can the patient get their care that makes the most sense? It goes back to the old emergency department utilization situation. Most patients who come to an emergency department really don't need to be seen there. They might need to be seen at their physician's office, but maybe their physician's office isn't open. Or maybe they need to be going to urgent care because it's something minor that can be dealt with a nurse practitioner or a physician's assistant. It's not immediate life-threatening. So you see that shifting of care away to ambulatory settings outside of the hospital to where it makes the most sense. Integration of freestanding facilities into networks of providers continues to happen. You have, for instance, you may have a single physician that has their own practice and they decide, you know what, I'd rather be a part of a very large group of physicians who own the practice rather than out there by myself. That there will be more economies of scale, there'll be more ways that they can benefit me. I don't have to be responsible for every aspect of my practice. There are others that can step in and do that. So you continue to see that integration happen. Increased scrutiny of documentation for support of reimbursement is requested. Oh, mercy, yes. These are areas, the OIG and others started out really focusing on hospitals and healthcare systems, and now they've gotten around all these years later to start focusing on the individuals and the smaller practices and the independent ones. And so they often now find themselves in that world that the hospital's been living in for about a decade. And so it's a bit of a shock at times. There's an increased pressure to become medical homes. where you basically have your patient and your patient stays with you and you coordinate their care. You really are taking care of all aspects of the patient, and um, you work with them so that they're getting the care that they need, staying out of a hospital or a healthcare system. There's an increased use of electronic health records going on in this area. Again, these are people that hung on to paper the longest because they didn't have the funds in many cases to purchase these expensive EHR systems. EHR systems are not cheap. Even for a single physician practice, they are unbelievably expensive, and they haven't had the money to be able to do it. And so they've held on to paper. Well, now they're kind of backed into a corner where paper no longer works, and they're going to have to pursue an electronic health record, which is very costly. And that's where you see that integration into networks happening. So in summary, the types of facilities and caregivers, we covered that. We've talked about accreditation and licensing standards. We touched on reimbursement. We talked about how information is managed. There are performance improvement and utilization management expectations in this on this group of providers and caregivers. And there are risk management and legal issues as well. If you're interested in web activities, this gives you a couple of activities that you can do to learn more about LCDs and NCDs. And that is it for Chapter 3. Thank you so much. I'll be back to talk to you again soon. I hope you're doing well. Stay safe and healthy.